Naririnig po ba?
Yes po, Doc.
Yeah. Okay, so we will now proceed sa ating parang movie yung dating. Yeah, isara ko lang yung mic ko. Oh, wait. Ayaw magsara yung mic. Oh, sandali lang. Ayun.
Niluto mo kagabi?
Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training, and I want to welcome you to the Solid Anatomy lecture on the orbit. In this video, we'll be covering muscles of the orbit, including the extraocular muscles. Also in the lecture, we'll discuss motor and sensory information of the orbit, and blood supply to the orbit. As a side note, the lecture pairs well with the lecture on the eye, another head and neck lecture in the Solid Anatomy series. I'll be back later for some clinical correlations and the end of session quiz, but for now I'm going to turn it over to our primary lecturer, Dr. John Phelan.
The orbits are the pyramidal cavities in the skull that protect the eyeballs. 7 bones contribute to the orbit: the frontal bone, the ethmoid bone, the lacrimal bone, the maxilla, the zygomatic bone, the sphenoid bone, and the palatine bone. Like all pyramids, the orbits have 4 walls, a base, and an apex. The base is just the orbital opening, which is surrounded by the orbital margin, or rim, and the apex is the optic canal in the lesser wing of the sphenoid bone. The medial walls are parallel to each other, while the lateral walls diverge and are at a nearly 90-degree angle to each other. The axes of the orbits are therefore at about 45 degrees to each other, but the eyeballs are oriented within the orbits such that the axes of vision are parallel. You may recall the bony structure of the orbit from the Solid Anatomy lecture on the skull. The majority of the superior wall, or roof, of the orbit is formed by the frontal bone, which separates the orbit from the anterior cranial fossa above. The frontal bone also forms the superior margin of the orbit. A supraorbital notch, or supraorbital foramen, is located just lateral to the medial end of the superior margin. The supraorbital neurovascular bundle supplying the anterior part of the scalp passes through this notch, or foramen. Anterolaterally, there is a shallow fossa in the frontal bone for the lacrimal gland. The lesser wing of the sphenoid bone contributes to the posterior part of the roof of the orbit. The hole in the lesser wing of the sphenoid at the apex of the orbit is the optic canal, through which passes the optic nerve and the ophthalmic artery. The frontal bone, the greater wing of the sphenoid bone, and the zygomatic bone each contribute to the lateral wall of the orbit. The frontal process of the zygomatic bone forms most of the lateral part of the orbital margin. Posteriorly, the superior orbital fissure is a gap between the greater wing of the sphenoid on the lateral wall and the lesser wing of the sphenoid on the medial wall. The superior orbital fissure transmits the ophthalmic division of the trigeminal nerve, the oculomotor nerve, the trochlear nerve, the abducent nerve, and the superior ophthalmic vein. Most of the inferior wall, or floor, of the orbit is formed by the maxillary bone. Minor contributions to the floor come from the palatine bone medially and the zygomatic bone laterally. Posteriorly, a gap between the maxillary bone on the inferior wall and the greater wing of the sphenoid on the lateral wall is the inferior orbital fissure. The inferior orbital fissure and the superior orbital fissure are continuous with each other, forming a boomerang shape whose apex points medially. The maxillary division of the trigeminal nerve and the inferior ophthalmic vein pass through the inferior orbital fissure. The lacrimal bone and parts of the ethmoid, frontal, and sphenoid bones form the medial wall of the orbit. On the inferior part of the medial wall, at the anterior edge of the lacrimal bone, is the opening for the nasolacrimal canal. The nasolacrimal duct travels down this canal and opens lateral to the inferior nasal concha in the nasal cavity. Posterior to the lacrimal bone is the delicate orbital plate of the ethmoid bone, which is sometimes called the lamina papyracea in observance of its paper-thin appearance. At its junction with the roof of the orbit are two tiny foramina that transmit the anterior and posterior ethmoidal nerves and vessels. The periosteum of the bones of the orbit is called the periorbita. It is continuous with the periosteal layer of the dura mater through the optic canal and the superior orbital fissure, and with the periosteum of the rest of the skull across the orbital margin and through the inferior orbital fissure. The eyeball only occupies about 40% of the volume of the orbit. The remainder is filled by fat. Physically separating the eyeball from the orbital fat is the bulbar fascia, or Tenon's capsule. The bulbar fascia is a fibroelastic membrane that forms the socket for the eyeball to rotate within. It is fused around the sclerocorneal junction along with the conjunctiva and covers the eyeball to the optic nerve posteriorly. The thin space between the sclera and the capsule is the episcleral space, which is filled with loose areolar tissue that allows the eyeball to roll around inside the capsule without friction. While the sclera is covered by the bulbar fascia, the cornea is covered by the bulbar conjunctiva, which, like the bulbar fascia, fuses along the sclerocorneal junction. The conjunctiva is a clear mucous membrane that lines the inner surface of the eyelids as the palpebral conjunctiva and reflects onto the cornea as the bulbar conjunctiva at the conjunctival fornices. The space between the palpebral and bulbar conjunctiva is the conjunctival sac. When the eyelids are together, that is, when the eye is closed, the conjunctival sac is closed. Goblet cells within the membrane secrete mucus that allows the inner eyelids to move across the cornea, as occurs when blinking the eyes, for instance, without friction. The mucus, together with the tears from the lacrimal gland and accessory lacrimal glands, and lipid secretions from the tarsal glands in the eyelids, protects the corneal epithelium and keeps it free from irritants such as dust. The core of the eyelids is a dense connective tissue plate called the tarsus. It is connected to the orbital margin via the membranous orbital septum, which becomes continuous with the periosteum. The orbital septum keeps the orbital fat from spilling past the orbital margin. The tarsal plate is also connected to the medial and lateral margins of the orbit by medial and lateral palpebral ligaments. Fibers of the orbicularis oculi muscle extend between the skin and eyelids and the tarsus and attach to the medial palpebral ligament. You may recall from the solid anatomy lecture on the face and scalp that this muscle is responsible for closing the eye. The eyelashes grow in a double or triple row of follicles at the free margins of the eyelid near a series of ciliary glands that secrete sebum. Infection of these glands results in what is commonly referred to as a stye. The lacrimal glands are almond-sized serous glands resting in a fossa of the frontal bone at the junction of the lateral and superior walls of the orbit. They consist of columnar epithelial acinar cells surrounded by myoepithelial cells. The acinar cells secrete lacrimal fluid, or tears, which flow through the tear ducts that open into the lateral corner of the superior conjunctival fornix. Tears flow inferomedially within the conjunctival sac and collect in the lacrimal lake. Tears are taken up by capillary action through lacrimal puncta into lacrimal canaliculi that end in the lacrimal sac. The lacrimal sac drains inferiorly into the nasolacrimal duct, which runs through the nasolacrimal canal of the skull and opens into the inferior meatus lateral to the inferior nasal concha in the nasal cavity. This pathway explains why our noses run when we produce a lot of tears.
Okay, let's go through the clinical correlation. Dr. Phelan discussed styes in the lecture, but I want to discuss styes and some other eyelid pathology in a little more detail here. So let's go through these questions. So first is, what is a chalazion? So a chalazion is a non-infectious inflamed tarsal gland. So these glands are also called meibomian glands. And this forms a kind of rubbery nodule. It irritates the eyeball. Now these irritate, but they're not generally that painful. So if you squeeze them, they're not that painful, but they are going to cause some irritation to the eyeball itself. Next, we have hordeolum. So a hordeolum is also the other way of saying stye, and we probably say stye because hordeolum is kind of a weird word. So this is an infection of the eyelid, and this is usually caused by Staph aureus. And this can be from either an internal stye or an external stye. And unlike the chalazion that we just talked about, these are painful. Now, an internal stye occurs because of the infection that's occurring in that meibomian gland. And then the external stye, which is a lot more common, which you see a lot of times in the office, is from obstruction of certain things. So an obstruction of an eyelash follicle, that's probably the most common thing that we see. The glands of Zeiss are another one. These are sebaceous glands on the eyelid margin. And then there's these other glands called the glands of Moll, which are ciliary glands. And these are apical glands on the eyelid margin as well. All right, so let's get back to that lecture.
Parasympathetic fibers to the lacrimal gland originate in the pons, in the lacrimal nucleus, which is associated with the superior salivatory nucleus. These preganglionic parasympathetic fibers run in the facial nerve and leave with its greater petrosal branch, just anterior to the geniculate ganglion. The greater petrosal nerve joins the deep petrosal nerve, which carries sympathetic fibers, to form the nerve of the pterygoid canal, which, as you might imagine, runs through the pterygoid canal at the base of the pterygoid process. The pterygoid canal opens into the pterygopalatine fossa, where the pterygopalatine ganglion resides. The parasympathetic fibers synapse here, and the postganglionic fibers join the zygomatic branch of the maxillary division of the trigeminal nerve, which enters the orbit through the inferior orbital fissure. The sympathetic fibers from the deep petrosal nerve pass through the ganglion without synapsing. They already synapsed at the superior cervical ganglion, and also join the zygomatic nerve to follow it into the orbit. The postganglionic, parasympathetic, and sympathetic fibers pass through a communicating branch of the zygomatic nerve to join the lacrimal nerve, a branch of the ophthalmic division of the trigeminal nerve, which they follow to the lacrimal gland. The parasympathetic fibers are secretomotor, meaning they cause tear production or lacrimation, while the sympathetics appear to be involved in vasoconstriction of arteries supplying the gland. The extraocular muscles, which are used to voluntarily move the eyeball to direct the pupil toward visual targets, are the superior, inferior, middle, and lateral rectus, and the superior and inferior oblique. They pierce the bulbar fascia and insert on the sclera. Their fascia is continuous with the bulbar fascia and with the periorbita. The rectus muscles take their origin off of a common cone-shaped tendon, the annulus of Zinn, or the annular tendon. It is continuous with the periorbita and the dural sheath of the optic nerve posteriorly, and forms a cone surrounding the anterior sides of the optic canal and part of the superior orbital fissure. Blood vessels and nerves entering the orbit through these openings pass through the annular tendon. The four recti muscles pass anteriorly along the respective sides of the bulbar fascia, pierce it, and insert on the sclera a few millimeters posterior to the sclerocorneal junction. The superior oblique muscle originates from the junction of the medial wall and roof of the orbit and passes anteriorly towards the superomedial corner of the orbital margin, where its pulley, or trochlea, is attached. The trochlea is a cartilaginous structure that blends in with the periorbita. The superior oblique becomes tendinous, passes through the pulley and turns backward, proceeding laterally until it pierces the bulbar fascia at about the center of the eyeball. It passes between the superior rectus muscle and the eyeball and inserts on the sclera posterior to the midline, or equator, of the eyeball. The inferior oblique muscle originates from the floor of the orbit just lateral to the opening of the nasolacrimal canal. It passes backward and laterally, pierces the bulbar fascia, and runs between the lateral rectus and the eyeball before inserting on the sclera deep to the tendon of the lateral rectus. The actions that the extraocular muscles can perform on the eyeball are named in reference to the change in position of the pupil as the eyeball is rotated within the bulbar fascia. Pointing the pupil superiorly is elevation. Pointing it inferiorly is depression. Pointing the pupil towards the median plane, or looking at the nose, is adduction of the pupil. Pointing the pupil away from the midline is abduction. The pupil may also spin around its axis. Spinning towards the midline is intorsion. Spinning away from the midline is extorsion. Intorsion and extorsion of the pupil allows the visual field to remain steady when the head is tilted. If you stare at a fixed object while tilting your head towards your right shoulder, your right pupil will intort and your left pupil will extort to keep your retinas level with the object you are staring at. The medial and lateral rectus muscles adduct and abduct the pupil, respectively. The superior and inferior rectus muscles also perform some abduction, while the superior and inferior oblique muscles, since they are originating on the medial extent of the orbit, perform some adduction. When the pupil is abducted, the superior and inferior rectus muscles are aligned with the axis of the eyeball and are able to elevate and depress the pupil maximally, respectively. As the pupil is adducted, the ability of the superior and inferior rectus muscles to elevate and depress the pupil lessens. When the pupil is fully adducted, they are ineffective at elevating or depressing the pupil. The superior and inferior oblique muscles act in the opposite manner to the superior and inferior rectus muscles. When the pupil is adducted, the superior oblique muscle maximally depresses it, while the inferior oblique maximally elevates it. The ability of the oblique muscles to act on the pupil lessens as the pupil is abducted. The inferior oblique is the best extorter, and the superior oblique is the best intorter. But the inferior rectus also extorts, while the superior rectus also intorts. The other voluntary muscle of the orbit is the levator palpebrae superioris. It originates on the lesser wing of the sphenoid, superior and anterior to the optic canal. It runs anteriorly, just superior to the superior rectus muscle. Its insertion tendon fans out to insert on the skin of the upper eyelid and the superior tarsal plate. When the muscle contracts, it elevates the upper eyelid. There is also a smooth intrinsic muscle in the superior eyelid, the superior tarsal muscle, that raises the eyelid during a sympathetic response. Denervation of the superior tarsal muscle or the levator palpebrae superioris muscle results in ptosis, or drooping of the eyelid. The oculomotor nerve provides motor innervation to the levator palpebrae superioris muscle and to all of the extraocular muscles except for the superior oblique and the lateral rectus, which are innervated by the trochlear nerve and the abducens nerve, respectively. Each of these three cranial nerves arises from separate nuclei bearing their names in the brainstem. The oculomotor nerve is carrying motor nerves from the oculomotor nucleus in the midbrain, and preganglionic parasympathetic nerve fibers from the Edinger-Westphal nucleus. The oculomotor nerve runs through the lateral wall of the cavernous sinus, the dural sinus just lateral to the fossa for the hypophyseal gland in the skull. The nerve enters the orbit through the superior orbital fissure and divides into a superior and inferior division. The superior division provides motor innervation to the superior rectus and to the levator palpebrae superioris muscles. The inferior division carries the parasympathetics to the ciliary ganglion, as described earlier, and the motor nerves to the medial rectus, the inferior rectus, and the inferior oblique muscles. The trochlear nerve arises from the trochlear nucleus in the midbrain and also runs in the lateral wall of the cavernous sinus before entering the orbit through the superior orbital fissure. It then quickly ends in the proximal end of the superior oblique muscle. The abducens nerve, or abducent nerve, originates in the abducens nucleus in the pons and runs not in the wall of the cavernous sinus, but actually through the sinus, surrounded by venous blood. It enters the orbit through the superior orbital fissure and plugs into the medial surface of the lateral rectus muscle. It may help you to recall the innervation of the lateral rectus if you remember its primary action is abduction. Abduction, abducens. With the motor nerves to the orbit covered, let's talk about sensory nerves. We've already discussed the most obvious sensory nerve of the orbit, the optic nerve, or cranial nerve number 2. The remaining sensory nerves that pass through the orbit are branches of the first and second, or ophthalmic and maxillary, divisions of the trigeminal nerve, cranial nerve number 5. As we've mentioned before in previous solid anatomy lectures, these nerves are sometimes abbreviated V1 and V2 for Roman numeral 5, first or second division. The cell bodies of the neurons making up the ophthalmic and maxillary divisions of the trigeminal nerve are located in the trigeminal ganglion that hides under the dura mater just lateral to the apex of the petrous portion of the temporal bone on the floor of the middle cranial fossa. Their central processes project back to the trigeminal sensory nuclei in the pons and the medulla. The peripheral processes of the ophthalmic nerve pass through the lateral wall of the cavernous sinus, then enter the orbit through the superior orbital fissure. The 3 main branches of the ophthalmic nerve in the orbit are the nasociliary nerve medially, the frontal nerve in the midline of the orbit, and the lacrimal nerve laterally. The lacrimal nerve carries sensory innervation from the lateral half of the eyeball and skin over the upper eyelid. The frontal nerve, which runs along the superior surface of the levator palpebrae superioris, is made up of the supraorbital nerve centrally and the supratrochlear nerve medially. The supraorbital nerve, which passes through the supraorbital notch, or foramen, on or in the orbital rim, and the supratrochlear nerve carries sensory innervation from skin over the upper eyelid and the forehead. The nasociliary nerve gives off several branches. The anterior and posterior ethmoidal branches run medially and enter the tiny foramina we mentioned in our discussion of the bony orbit to provide sensation to the nasal cavity and to the mucosa of the ethmoidal sinuses. The long ciliary nerve provides sensory innervation to the medial half of the eyeball. The infratrochlear nerve carries sensory innervation from more skin outside the orbit. You're probably aware of the tear reflex. Someone pokes you in the eye, and your lacrimal gland produces tears. The nerve in the sensory pathway of this reflex is the ophthalmic division of the trigeminal nerve. Cut that nerve, and it stops reflexive lacrimation, but not emotional lacrimation. The maxillary division of the trigeminal nerve also runs in the dura mater, making up the lateral wall of the cavernous sinus. But instead of passing through the superior orbital fissure, it drops through the foramen rotundum to enter the pterygopalatine fossa. Several branches are given off in the fossa that head elsewhere, but the remaining portion of the nerve enters the orbit through the inferior orbital fissure. We already mentioned that the zygomatic nerve gives a communicating branch that allows autonomic nerve fibers to reach the lacrimal gland. The remaining branches of the zygomatic nerve innervate skin over the cheek. The infraorbital nerve runs through the infraorbital groove and canal on the floor of the orbit and opens on the face through the infraorbital foramen. It does not innervate anything in the orbit, just skin on the lower eyelid, upper lip, and lateral nose. The ophthalmic artery supplies blood to the eyeball and orbit. The blood supply to the eyeball is covered by the central artery of the retina and the posterior ciliary arteries. The remaining branches of the ophthalmic artery follow the branches of the ophthalmic nerve and are named identically. The superior and inferior ophthalmic veins, which pass through the superior orbital fissure, drain the orbit directly into the cavernous sinus. The central vein of the retina may drain into one of the ophthalmic veins or drain directly into the cavernous sinus.
So that covers the orbit. Now I want you to pause the video and answer the end of session quiz questions. There will be some questions covered that were not discussed in the lecture, but just do your best and then we'll go through the answers together. Let's get going. First question. What is the name of the inner membranous lining of the eyelid? Easy one, remember that's the conjunctiva. Next, which artery pierces the optic nerve? That's going to be the central artery of the retina. Next, from what ganglion do the lacrimal glands receive stimulation? That's going to be the pterygopalatine ganglion. Next, if you cut the lacrimal nerve back at the apex of the orbit, will you retain lacrimal gland function? So the answer to this is yes. The lacrimal secretomotor nerves actually don't run with the lacrimal nerve from below until almost at the gland itself. Next, what is the action of and the nerve supply to the levator palpebrae? So this is going to be raises the eyelid, and this is going to be ocular motor nerve, and that's going to be cranial nerve 3. Next, which artery supplies the lacrimal gland? And that's going to be easy, the lacrimal artery. Next, what are the check ligaments of the eye that check AB and adduction, so abduction and adduction of the globe? So that's going to be your medial and lateral palpebral ligaments. Next, to what does the term palpebra refer? That's going to be referring to the eyelid. Next, which 3 bones comprise the outer orbit, each contributing 1/3? That's going to be your frontal, maxillary, and zygomatic. Next, which way will the eye deviate if the abducens nerve, so cranial nerve 6, is lost? It's going to go medially. Next, what is the most superior muscle of the eye? That's going to be your levator palpebra superioris. Next question. What portion of the levator palpebrae muscle is controlled by the superior cervical ganglion? So this is sympathetic nervous system and is responsible for ptosis and Horner syndrome. That's going to be the superior tarsal muscle. All right, so we're almost done. Now we actually provided some images for you to label. Recalling these images in a time setting will help you to perform well on the practical part of your exam. So label the images and then we'll be finished. Thanks.
In this section, we'll look at the eye and its surroundings. We've already seen the nerves of the orbital region in part 3 of this tape. In this section, we'll first look at the bony features of the orbital cavity, then we'll look at the eye itself, then at the eye muscles, and lastly, the eyelids and lacrimal apparatus. Let's start with the bones. This is the bony orbit, or orbital cavity. It's described as having a roof, a floor, a medial wall, and a lateral wall. The rim of the orbit is called the orbital margin. It's thick and clearly defined above, laterally, and below. Here, medially, the orbital margin is less distinct. The medial wall of the orbit blends with the contours of the nose and the central part of the forehead. The orbital margin curves distinctly backwards, both above and below. Because of this, the orbital margin is much further back laterally than it is medially. This reflects an important fact about the orbital cavity. It doesn't face directly forwards. We can see this best in a skull in which the roof of the orbit has been removed. This lets us look down into the orbit from above. The medial wall of the orbit faces directly forward, but the lateral wall is angled outward by about 45 degrees, so that the center line of the orbit is a little over 20 degrees off the midline. As we saw in tape 4, several bones are involved in forming the orbit. Starting medially, this is part of the ethmoid bone. This is the underside of the frontal bone. This is the zygomatic bone. This is part of the maxilla. So is this. And this is the lacrimal bone. Back here are the greater and lesser wings of the sphenoid bone. Here at the narrow apex of the orbit are the optic canal and the superior orbital fissure. The optic canal transmits the optic nerve and ophthalmic artery. The superior orbital fissure transmits the other nerves that enter the orbit and the superior orbital vein. In the living body, the inferior orbital fissure, which forms an apparent gap between the floor and the lateral wall, is bridged over with fibrous tissue. This groove, the lacrimal groove, leads downwards into the opening for the nasolacrimal duct, which takes tears to the nasal cavity. The rim of the lacrimal groove is formed by the posterior lacrimal crest behind and the anterior lacrimal crest in front. The medial palpebral ligament is attached here, the lateral one here. The palpebral ligaments hold many of the anterior structures of the orbit in place. Now we'll move on to look at the main externally visible parts of the eye itself. In life, we see only a small part of the eye. Even at the limit of eye movement, we see less than half of its circumference. Here's the eye, seen from above. It occupies only the anterior part of the orbit. The space behind it is largely occupied by fat that's been removed in this dissection. The tough outer coat of the eye is the sclera. The sclera extends from here behind, where the optic nerve passes through it, all the way around to here in front, where it becomes continuous with the transparent cornea. The cornea is the transparent window that allows light to enter the eye. The cornea is more sharply curved than the sclera. It bulges forwards. Behind the cornea, the colored iris forms an incomplete partition within the eye. At the center of the iris is a clear opening, the pupil. The size of the pupil is constantly changing to limit the amount of light that enters the eye. The iris is chiefly formed of muscle fibers. Fibers arranged radially cause the pupil to dilate. Fibers arranged circumferentially, both here and out here, make it constrict. The lens of the eye is just behind the iris and the pupil. Here, light from a slit lamp is coming in from the left side. Down here, where it's very bright, the light is hitting the iris. Here, where it's fainter, it's hitting the anterior surface of the lens. The internal structures of the eye are so delicate and so readily displaced that they can't be well shown by dissection. They're better understood by referring to microscopic images and diagrams, to which I hope you'll have access. Now we'll move on to look at the extraocular muscles. There are 7 of them. One, as we'll see, raises the upper eyelid. The other 6, the 4 rectus muscles and the 2 oblique muscles, move the eye. The best way to look at these muscles is from above. Here, we're looking down into the orbit in a dissection in which the orbital roof has been removed. We'll start by looking at the rectus muscles. To see them, we'll take these two muscles, the levator and the superior oblique, out of the picture. We'll also remove some of the fat that largely fills the posterior part of the orbit. Here are three of the rectus muscles: superior, lateral, and medial. To see the inferior rectus, we'll remove the superior rectus, the optic nerve, and the rest of the orbital fat. Here's the inferior rectus muscle. Between the origins of the rectus muscles, the optic nerve emerges. The rectus muscles arise together from inside a ring of fibrous tissue, the annulus tendineus, of which this is the upper part. The annulus is attached to the periosteum of the apex of the orbit. Its ring of attachment, represented in blue here, encircles the optic canal and this part of the superior orbital fissure. The optic nerve, the ophthalmic artery, and several of the nerves to the orbit pass through the annulus. The rectus muscles thin out into four flat tendons as they pass forwards around the eye. They insert into the sclera quite far forward. To see where they insert, we'll go round to a view from in front. Here's the insertion of the superior rectus. Here's the lateral. Here's the inferior. Here's the medial. The main actions of the rectus muscles are obvious. The superior and inferior rectus muscles turn the eye upwards and downwards. The lateral and medial ones turn it outwards and inwards. The inferior and superior rectus muscles have another action too. They don't only pull top or bottom of the eye straight backwards, they also tend to rotate it a little about its long axis. The superior rectus, acting alone, would rotate the top of the eye inward as we look up. The inferior rectus would rotate it outward as we look down. In fact, the rectus muscles don't act alone. They act in conjunction with the two oblique muscles, the inferior oblique and the superior oblique. We'll add those to our picture, starting with the superior one. Here's the superior oblique muscle. Like the rectus muscles, it arises from the annulus. The superior oblique narrows into a tendon, which passes around this sling of fibrous tissue, the trochlea. The trochlea is attached to bone here, behind the orbital margin. The trochlea acts as a pulley. The superior oblique tendon fans out, passing deep to the superior rectus to insert into the sclera on top of the eyeball. We'll go round to our view of the eye from in front and add the oblique muscles to that picture. Here's the trochlea. Here's the superior oblique tendon. The superior oblique muscle, acting alone, would rotate the top of the eye medially. The inferior oblique muscle is down here. It's the only extraocular muscle that doesn't arise from the annulus. It arises here, behind the inferior orbital margin. It inserts into the sclera quite far back. To see that, we'll go round to our view from above and behind. Here's the inferior oblique, inserting into the sclera between the lateral rectus and inferior rectus muscles. The inferior oblique, acting alone, would rotate the top of the eye laterally. The oblique muscles act in conjunction with the rectus muscles, the inferior oblique with the superior rectus, and vice versa. This prevents our eyes from rotating about their long axes as we look up and down. The last of the 7 extraocular muscles to look at is the levator of the upper eyelid, levator palpebrae superioris. The levator lies just above the superior rectus muscle. Here it is. Arising from the annulus fibrosus back here, the levator fans out to become a broad tendon which inserts, as we'll see later, mainly into the tarsus of the upper lid. Incorporated in the underside of the levator is a strip of smooth muscle, the superior tarsal muscle, that's innervated by sympathetic fibers. Changes in the tone of this smooth muscle cause our upper lids to droop when we're tired and open wide when we're excited. As we saw in the section on the cranial nerves, the extraocular muscles get their nerve supply from the third, fourth, and sixth cranial nerves. The superior oblique is supplied by the fourth nerve, the trochlear. The lateral rectus is supplied by the sixth nerve, the abducens. The other 5 muscles are supplied by the third nerve, the oculomotor. In the images that we've seen so far, the muscles have been dissected bare to show them clearly. But in reality, each of the muscles, as it passes forwards, becomes surrounded by a sliding sheath of fibrous tissue. The fibrous sheaths of adjoining muscles blend together to form a hood above and below the eye. This hood is firmly attached to periosteum at 2 points, here laterally and here medially. These fibers of attachment form the posterior parts of the lateral and medial palpebral ligaments. Indirectly, they hold the eye in position in the orbit. The tendon sheaths of the muscles are also continuous with this sheath of fibrous tissue, the capsule of the globe, that surrounds the posterior 2/3 of the eyeball. Now that we've looked at the extraocular muscles, we'll move on to look at the eyelids and the lacrimal apparatus. The eyelids form a movable protective covering for the eye. The upper and lower lids are much alike. We'll look mainly at the upper one. In looking at the structures that form the eyelids, we'll switch between a dissection from in front to one in which the structures have been divided in steps, a layer at a time, giving us this lateral view. The eyelids are covered on the outside with skin that's extremely thin and mobile. They're covered on the inside by a thin sensitive membrane, the conjunctiva. This is the conjunctiva. Conjunctiva also covers the front of the sclera. The conjunctiva that covers the sclera, the bulbar part, and the conjunctiva that lines the lid, the palpebral part, are continuous at this fold, the conjunctival fornix. The conjunctiva is continuous with the skin at the margin of the eyelid. Directly beneath the skin of the eyelids, which we'll remove, is the orbicularis oculi muscle. As we saw in part 1 of this tape, the orbicularis extends beyond the margins of the orbit onto the forehead and the cheek. It's such a thin muscle, parts of it are almost colorless. Medially, many of its fibers arise from this structure, the medial palpebral ligament, which is attached to bone here at the anterior lacrimal crest. The more outlying fibers of orbicularis arise from bone here, around the lacrimal groove. Laterally, the innermost fibers of orbicularis insert into bone here. The more outlying fibers have no bony attachment. This is part of the orbicularis. It's been divided along this line. Directly beneath it is this layer of fatty fibrous tissue, the orbital septum, that extends into the lid from the periosteum at the orbital margin. The orbital septum separates the contents of the orbit from the facial soft tissues. Here beneath the orbicularis is the structure that gives the eyelid its shape, the tarsus. It extends from here to the lid margin.
Cute.
To see the tarsus from in front, we'll remove the orbicularis muscle and then the orbital septum. We have also removed much of the orbital fat. The tarsus is here. If we put something underneath it, we can see its upper border. The tarsus is tethered at each end to the palpebral ligaments. The tarsus is quite flexible. It stiffens the eyelid and gives it a curvature that varies so that the shape of the eyelid conforms to the changing curvature of the underlying eye. Within the thickness of the tarsus are numerous tarsal glands. This is one of them. The tarsal glands open here, right along the margin of the lid. The tarsal glands produce an oily secretion which prevents the spillage of tears. This structure, coming down from behind, is the levator muscle. This is its tendon. The levator tendon inserts mainly into the tarsus. Its most lateral and medial fibers are attached to the palpebral ligaments. Here's the orbital margin. Here, just below and behind it, is the lacrimal gland, which secretes tears. It lies in this hollow in the roof of the orbit, the lacrimal fossa. The many small ducts of the lacrimal gland open into the conjunctival fornix up here. Tears leave the space in front of the eye through two small openings called puncta. Here's the lower punctum. To see the upper one, we'll roll the upper lid outwards. Here's the upper punctum. To see where the puncta lead, we'll look at a dissection in which the orbicularis has been removed and blue material has been injected into the puncta. Here's the upper punctum. Here's the lower one. Leading from them are the canaliculi. Here's the upper canaliculus. Here's the lower one. The two canaliculi converge behind the medial palpebral ligament, which we'll remove. The canaliculi join together and enter this reservoir, the lacrimal sac. The lacrimal sac is surrounded by the fibers of origin of the orbicularis muscle. When we blink, the pressure from these muscle fibers squeezes tears from the lacrimal sac down into the nasolacrimal duct. Now that we've looked at the eyelids and lacrimal apparatus, let's review what we've seen of the eye and its surroundings. Here's the orbital margin, the optic canal, the superior orbital fissure, the inferior orbital fissure, the lacrimal groove, the posterior lacrimal crest, and the anterior lacrimal crest. Here's the sclera, the cornea, the iris, and the pupil. Here are the rectus muscles, superior, lateral, medial, and inferior, and the oblique muscles, superior and inferior. Here's the trochlea. Here's the annulus tendineus. Here's the conjunctiva, palpebral and bulbar. Here's the orbicularis oculi muscle, the orbital septum, the tarsus, and the tarsal glands. Here's the lacrimal gland, the upper and lower puncta, the canaliculi, the lacrimal sac, and the nasolacrimal duct.
Okay, so we'll have a short break after this. Do you have any questions? Do you have any questions?
Wala pa naman po, Doc.
Okay. I hope the videos that were shown were able to reinforce the lectures earlier by Dr. Danisay. O sige, so let's have a 10-minute break. We'll resume at 11:05, sorry. 11:05 for the nose and paranasal sciences. Okay. So that's a superior view. We're looking from the top. Okay, so you have part of your anterior cranial fossa here. So this muscle now is called your, can you please name anybody?
Superior or
Superior rectus. Okay, so that will clearly be your superior rectus. Please take note of the attachment of the muscle, an extraocular muscle, which is on the eyeball. Okay, okay, take note. It is attached, okay, to the eyeball. Now, why am I saying that? It's because when you crack the bone, no, the portion of the bone of the cranial fossa that's overlying the orbit, when you crack that, it is not the superior rectus that you will see first. It is the levator palpebrae muscle. And how can you differentiate that? It's because the levator palpebrae muscle will now invest itself towards the palpebral portion. Diba? Do you remember when we were identifying the ocular muscles also? And then we were looking at the frontalis and then to the occipitalis. And then we said, merong portion we're lifting up that the upper area, okay, as we were trying to identify the ocularis of oculi muscle, meron tayong na-pull, na-retract na portion. That's the insertion, okay? Ito yung putol yun. If we retract it down, nag-i-invest siya dito sa space. Now, that's the levator palpebrae muscle. Kaya, yun yung nakapatong dyan. Hindi agad-agad yan ang makikita mo. So, the key there is for you to always look at where the muscle is attached. Okay? So, let's now go to the next picture. Okay, so here, very clearly, from the tendon going to the eyeball. Ano naman tong cut muscle na nakikita nyo? Looking at it from the lateral side, because this is your nasal bone. What is this now?
lateral right.
Innervated by
6. Cranial nerve 6.
LR6. Okay, LR6. Very good. Okay. Next. So you have here the trochlea. Okay. Okay. So what is this muscle? Ay, sorry. Hindi ito. The trochlea is in relation to what muscle? Extraocular muscle. Superior oblique. Okay? Superior oblique because of the trochlea. Ano ngayon yung innervation ng superior oblique?
Or
Cranial nerve 4.
SO4. Okay? So, ito yung superior rectus innervated by
oculomotor.
oculomotor along with the medial rectus and the inferior rectus. Hindi nakikita usually ang inferior rectus dito sa model na to. Sorry. Now, okay? So, you have the inferior rectus more visible on the side view. Okay? And this is now your inferior oblique, ha? Ito yung inferior oblique. Okay. Sige, so tapos na tayo dyan. Now, let's introduce ourselves now to the next topic, which is your nose and the paranasal sinuses. Just quickly to review or revisit the model that was shown. This is this is a mid-sagittal section. Why do we say it is a mid-sagittal section? Because the septum is still intact. So, wall yan. You have to take it off to see the turbinates, the conchae, or the meatus. So that will be demonstrated by Dr. Akland later. So this one is your nasal septum. Okay, so it's made up of different portions also depending on the area. The inferior portion that's different from the one on top, and then this portion. So listen carefully kay Dr. Akland when he identifies and highlights each portion of the nasal septum. Okay? So what's also important here is that you're able to identify some important sinuses, your frontal, and then your very big sphenoid. Okay? Oh yes, very big sphenoid. Tama ba? Yes. And then let's go. Now, do you remember now this model? Did you touch it and attempt to identify the parts? I hope so. Okay, so let's zero in on the area of the nose again. So this one is the sphenoid, which corresponds here. And then this one now corresponds to this portion here, up there. Okay? So this one is your pituitary gland. So here is the nasal cavity now. We took out the nasal septum. So we're looking at the lateral wall of the nasal cavity. So you have your superior, middle, and inferior concha. Diba? So it's mucosa covering bone
Paano ngalan, ma?
structures. And then, if you notice, there are spaces in between the three concave. So you have your superior, inferior, and superior, middle, and inferior hiatus. Okay? So memorize and absorb which paranasal sinuses will drain or empty into the nasal cavity plus the nasolacrimal duct na lecture kanina sa DIT, yung Doctors in Training sa first video. Okay? However, I'd like you to please take note of the tabulation provided by Snell. Tingnan nyo yon kasi it is a more specific structure, okay, that these paranasal sinuses drain into. It will not be enough for us now to ask at this level na they drain towards the superior, middle, and inferior meatai. So, ibig sabihin, meron pang mas specific structures. If you want, you can open your Snell now, okay, for the paranasal sinuses, and then wait for Dr. Aklan to actually demonstrate to you sa cadaver saan mo makikita yon. Because there will be a lot of movement, okay, of this space later. Now, I'd like to also highlight this area at the posterior aspect of your nasal, papunta na siya actually sa nasopharynx, so this is the nasopharynx. There are key structures there, basically this elevation, which is because of a cartilaginous structure. And this is called your torus tubarius. And you'll have your opening here, which communicates with the external auditory meatus. So opening towards the external auditory meatus or the eustachian tube. So you know very well that this aperture equalizes the atmospheric pressure, okay, with what is the internal pressure inside the nasal and the oral cavity. Okay? So kapag kunwari now, clinically speaking, if this area becomes engorged by inflammation, pwedeng galing dito, pwede rin galing sa labas, okay, from the ear or here at the posterior aspect of your nasopharynx. This one becomes inflamed, namamagayan, so the aperture becomes smaller. Yan yung minsan na nararamdaman nyo parang clogged, nagbibingi kayo, okay? It is because of the inflammation resulting from the soft tissue surrounding this aperture. Okay, so this one is important. Dr. Aklan will also mention this. Yun is a pharyngeal recess. Minsan, sa cut section, sa sagittal section, malilito ka kasi akala mo may dalawang butas, okay? One more related to the posterior aspect of your nasal cavity, and another one more related to the posterior muscles here and the vertebra. So mamaya, try to look at how Dr. Aklan will orient the camera. So you are going to be confident when defining the recess from the aperture. Okay? Okay, so having said that, we are now ready to proceed to the video. Okay? Uy, sorry, meron pala tayong specimen. So, just zero in. Pareho lang, no? Middle and inferior concave, middle and inferior meatus. And then your sinuses, okay? In relation to the pituitary, okay? So, yeah. And then the torus tubarius here. I cannot enlarge it anymore. So, this is your torus tubarius, okay? And then the esophageal recess. Okay, so we're ready to watch. Umi lang po.
In the next 3 sections, we'll look at the parts of the head and neck that are involved in 2 vital functions: breathing and eating and drinking. To get a preview of these major topics, we'll look at a specimen that's been divided in the midline. The passage for air and the passage for food and liquid begin separately at the nose and the mouth. Air passes backward through the nasal cavity and the nasopharynx. Food and liquid pass backward through the oral cavity. The two passages unite here. Air, food, and liquid all pass through this common passage, the oropharynx. The two passages separate again here, in the hypopharynx. Food and liquid pass backward into the esophagus on their way to the stomach. Air passes forward through the larynx and into the trachea on its way to the lungs. So, the lines of travel for air and for food and liquid cross over in the oropharynx. It's important that air on the one hand and food and liquid on the other hand don't pass upward or downward into the wrong passage. To take care of this, there are important mobile structures above and below the oropharynx that act as separators. These are the soft palate above, and the epiglottis, and vocal cords below. As we'll see in later sections of this tape, the structures that form the passages for air and for food and liquid are also involved in a further important function, the production of voice sounds. In this section, we'll look at the upper part of the air passage. We'll look at the external nose, the nasal cavities, the paranasal sinuses, and the nasopharynx. We'll start by looking at the bony structures that surround these spaces. The bony opening for the nose is called the piriform aperture. Inside it, there are two nasal cavities, a right and a left, separated in the midline by the nasal septum. To get a better look inside, we'll divide the skull in the frontal plane along this line. There's a lot to see here. Let's get ourselves oriented. Here's the hard palate. Here's the floor of the anterior cranial fossa. Here are the medial walls of the orbits. Here are the two nasal cavities. The septum dividing them is a little off-center, which is not unusual. The roof of each cavity, formed by the cribriform plate, is very narrow. The medial wall of each nasal cavity, formed by the septum, is smooth and featureless. So is the floor. By contrast, the lateral wall is marked by a number of features, most notably by these three delicate bony projections, the conchae, also known as the turbinate bones. This is the inferior concha, this is the middle concha, this is the much smaller superior concha. The three conchae partially divide the air passage into three parts: the inferior meatus, the middle meatus, and the superior meatus. Here's the back of the orbital cavity. Below it is the hollow space in the maxilla, the maxillary antrum, which we'll look at later. At about the level of the floor of the orbit, the nasal cavity becomes much narrower. The narrowing is caused by the presence of this collection of small hollow spaces, the ethmoid air cells. We'll see more of these in a minute. To see more of the septum and the nasal cavity, we'll look at it in a skull that's been divided just to the left of the midline. Here's the bony part of the nasal septum. It's formed by this part of the ethmoid bone, the perpendicular plate, and by this small bone that we haven't encountered up till now, the vomer. The lowest part of the septum is formed by the maxilla and by the palatine bone. Here's the divided left cribriform plate. This projection above it is something we've seen before. It's the crista galli. The frontal section we were looking at was divided here, just behind the crista galli. Now we'll remove the septum to get a good look at the lateral wall of the nasal cavity. The roof of the nasal cavity runs along this line, rising to its highest point along the length of the cribriform plate. Here are the conchae again, superior, middle, and inferior. There are several openings in the lateral wall of the nasal cavity. They're partly hidden by the conchae. We'll see them in a minute. The lateral wall of the nasal cavity is formed partly by the maxilla, partly by the ethmoid bone, and partly by the perpendicular part of the palatine bone. Further back, where the nasal cavity becomes the nasopharynx, the lateral wall is formed by the medial pterygoid plate. The large facial bones that surround the nasal cavity, the frontal bone, the maxilla, the sphenoid, and ethmoid bones, are hollow to a greater or lesser extent. The hollow spaces in these bones contain the paranasal sinuses, which, in the healthy living body, are filled with air. The paranasal sinuses all communicate with the nasal cavity. To see the sinus cavities, we'll look at a skull in which part of the bone that overlies each sinus has been removed. Here's the cavity for the right frontal sinus. There's a left one, too, on the other side of this partition. The frontal sinus extends upward behind the lower part of the forehead, and also, to a variable extent, backwards, between the roof of the orbit and the floor of the anterior cranial fossa. Here's the cavity for the right maxillary sinus, also known as the maxillary antrum. It extends backwards to the part of the maxilla that borders the pterygomaxillary fissure. It extends downwards almost to the root of the upper molar and premolar teeth. The medial wall of the maxillary sinus is also the lateral wall of the nasal cavity. Its roof forms a large part of the floor of the orbit. The sphenoid sinuses occupy the central part of the sphenoid bone. This opening has been made to show the right sphenoid sinus. To see it better, we'll look at the skull divided in the midline. Here's the right sphenoid sinus again. Above the sphenoid sinus is the floor of the anterior cranial fossa and the sella turcica. Behind it is the basilar part of the occipital bone. In front of it is the high part of the nasal cavity. Below it is the roof of the nasopharynx. Lastly, we'll come round to the front to look at the collection of small cavities that contain the ethmoid air cells, collectively referred to as the ethmoid sinus. These extend from just behind the nasolacrimal duct all the way back along the medial wall of the orbit. As we've seen already, the ethmoid air cells lie between the medial wall of the orbit and the lateral wall of the upper part of the nasal cavity. Before we go further, we need to catch up on something that we left unfinished in the previous section, understanding the ethmoid bone. We've encountered the various parts of the ethmoid bone, but till now we've put off seeing the whole of it. We'll do that now. Then we'll come back and look at the openings of the paranasal sinuses. The ethmoid bone is a fragile coalition of parts. The best way to see all of them is to go back to the skull that was divided in the frontal plane. All of this is the ethmoid bone. This part, the perpendicular plate of the ethmoid, forms a large part of the bony nasal septum. This upward projection is the beginning of the crista galli, which rises up in the floor of the anterior cranial fossa. On each side of the crista galli are the cribriform plates, which we've seen already from above and from below. The most lateral part of the ethmoid bone is this paper-thin layer, the lamina papyracea, which forms this part of the medial wall of the orbit. Between the lamina papyracea and the upper part of the nasal cavity are the ethmoid air cells, as we've seen. The superior and middle conchae are also parts of the ethmoid bone. The ethmoid bone is joined to the frontal bone above, the maxillae below, and the central part of the sphenoid bone behind. Now that we've seen the ethmoid bone, we'll return to the cavities for the paranasal sinuses and see how they connect with the nasal cavity. We'll look at the openings for the frontal and maxillary sinuses first. Here's the frontal sinus cavity. Here's the maxillary sinus cavity, seen through an artificial opening. The frontal and maxillary sinuses both open in this complex area beneath the middle concha, which we need to look at in more detail. In a dry skull, there are two large irregular openings from the nasal cavity into the maxillary sinus, separated by this flake of bone, the uncinate process. In the living body, all of this opening and much of this one are closed off by soft tissue. The real opening of the maxillary sinus is back here. If we look in from in front, we can see that the opening is quite high on the medial wall of the maxillary antrum. The frontal sinus opens into the nasal cavity by way of a narrow passage, the frontonasal duct. The frontonasal duct starts above the uncinate process and runs upward and forward to reach the frontal sinus. The frontal and maxillary sinuses open into the nasal cavity, not directly, but into a narrow side chamber located here, called the infundibulum. The infundibulum isn't apparent in a bony specimen. We'll see it when we look at the soft tissues. Now we look at the openings for the other sinuses. The sphenoid sinus opens into the nasal cavity here, above and behind the superior concha. The ethmoid air cells, which are up in this region, have several small openings into the nasal cavity. Some of these are behind the middle concha, some of them are below it. There are two more openings to see in the lateral wall of the nasal cavity. The opening for the nasolacrimal duct, or tear duct, and an opening for nerves and blood vessels, the sphenopalatine foramen. As we've seen, the bony passage for the nasolacrimal duct starts here. The nasolacrimal duct, which is quite short, passes downwards and backwards to open beneath the inferior concha. Here's its opening. The last opening to look at, the sphenopalatine foramen, is the inner end of a short tunnel for blood vessels and nerves to the nose and palate. On the inside, it opens near the back of the superior meatus. We'll go all the way round to the outside to see the other end of the sphenopalatine foramen, which is here, in the depths of the pterygomaxillary fissure. Now that we've seen the bony features of the nasal cavity, we'll move back and look at the bones that surround the nasopharynx. Here's the posterior opening of the nasal cavity, the choana, or posterior nares. Its lateral wall is formed by the medial pterygoid plate. The medial pterygoid plate ends below in the hamulus. This piece of colored material represents the cartilage of the auditory tube. The cartilage forms an incomplete tube, open on the underside. Close to the medial end of the cartilage is a group of openings in the base of the cranium that we've seen before from a different angle. The foramen ovale, foramen spinosum, the opening of the carotid canal, and the jugular foramen. The roof of the nasopharynx, formed by the underside of the sphenoid and the basal part of the occipital bone, slopes downward toward the foramen magnum. To complete our picture of the bones around the nasopharynx, we'll add the cervical vertebrae. Here's the anterior arch of the atlas, and here's the odontoid process of the axis. Now, let's review what we've seen of the bony structures that surround the upper part of the air passage. Here's the piriform aperture and the nasal septum. Here are the posterior nares, or choanae. Here's the inferior concha, the middle concha, and the superior concha. Here are the superior meatus, middle meatus, and inferior meatus. Here's the cavity for the frontal sinus, the maxillary sinus, the sphenoid sinus, and here are the ethmoid air cells. Here are the cribriform plates, the uncinate process, and the vomer. Here are the frontonasal duct, the openings for the maxillary sinus, the sphenoid sinus, and the ethmoid air cells, posterior and anterior. Here are the openings for the nasolacrimal duct and the sphenopalatine foramen. Now that we've looked at the bony features of the nasal cavity, the paranasal sinuses, and the nasopharynx, let's see what this region looks like in the living body. We'll start with the entry to the air passage that forms such a distinctive feature of the face, the external nose. The skin over the upper, bony part of the nasal framework is thin and mobile. The skin over the lower, cartilaginous part is thicker and fixed to the underlying structures. The openings which form the beginning of the air passage are the nostrils, also called the anterior nares. We'll remove the skin from one half of the nose so that we can see the underlying structures. The edge of the bony opening for the nose, the piriform aperture, is here. Here's the nasal bone. The two nasal bones, united in the midline, form the bridge of the nose down to here. From here, almost to the tip, the bridge of the nose is formed by the front edge of the septal cartilage, which we'll see more fully in a minute. On each side, the framework of the nose is formed by two slender pieces of cartilage, the lateral cartilage and the alar cartilage. The lateral cartilage is thin and flat. In front, it's continuous with the septal cartilage. The alar cartilage has two parts, the lateral crus and the medial crus. The lateral crus forms the curved outer framework of the nostril. The medial crus turns sharply backwards, ending here. Together, the two medial crura form the framework of the lowest, most anterior part of the nasal septum, which is called the columella. To get a good look at the nasal septum, we'll divide the bone and soft tissues along this line and remove the left side of the face. Here's the nasal septum. Before we look at it, let's get oriented. Here's the anterior cranial fossa. Here's the bony palate, or hard palate, with the soft palate extending behind it. Here's the oral cavity. Here's the opening of the right nasal cavity. Behind it is the nasopharynx, which we'll look at in a minute. The nasal septum extends from here behind to here in front. This small part of the septum is covered with skin. The rest of it is covered with this layer of mucous membrane. We'll remove a small piece of the mucous membrane so that we can appreciate its thickness. The highest part of the septum is the specialized olfactory area. It contains some of the fibers and nerve endings of the olfactory nerve, which are the sensory receptors for our sense of smell. The cribriform plate, which the olfactory nerve fibers go through, is at this level. Now we'll remove all the mucous membrane from the septum so that we can see the underlying cartilage and bone. This part of the septum is bone, as we've already seen. This part is formed by the septal cartilage. In this specimen, there's an unusual defect in the cartilage here. In front, the septal cartilage forms the bridge of the nose down to here, then runs downward and backward to attach to this bony prominence on the maxilla, the anterior nasal spine. Now we'll remove the whole of the nasal septum so that we can see the lateral wall and floor of the nasal cavity. The inside of the nostril, up to the lower border of the lateral cartilage, which is here, is called the nasal vestibule. It's lined with skin. The rest of the nasal cavity is lined with mucous membrane. Here are the conchae, superior, middle, and inferior. The mucous membrane that covers them is richly supplied with mucus glands and with blood vessels. The complex surfaces of the conchae have important functions in humidifying the inspired air and warming it. This olfactory area, like the corresponding area on the septum, contains olfactory nerve fibers and nerve endings. All the paranasal sinuses and the nasolacrimal duct for the tears open into the nasal cavity. To see their openings into the nasal cavity, we'll remove the conchae.
Make your guess.
The inferior concha was here. Here beneath it is the opening for the nasolacrimal duct. Beneath the middle concha, which was here, is a deep groove called the semilunar hiatus. To see where this leads, we'll retract its lower border with this thread. The semilunar hiatus leads into a narrow, irregular side chamber called the infundibulum. The infundibulum receives the openings of the frontal sinus and the maxillary sinus. Sometimes the more anterior ethmoid air cells open into the infundibulum too. Sometimes, as in this case, they open separately, below the middle concha. Here's where the superior concha was. The more posterior ethmoid air cells open below the superior concha. The sphenoid sinus, which is this cavity, opens forwards into the highest part of the nasal cavity, the sphenoethmoidal recess. Here's the frontal sinus cavity in a different specimen. The opening to the frontonasal duct is behind here. To see the other sinus cavities, we'll take a look from the outside at a dissection in which all the facial soft tissues have been removed. Here's the maxillary sinus cavity, opened from in front. The opening from the sinus into the infundibulum is all the way up here on the medial wall. Here are the ethmoid air cells, with the lamina papyracea removed. This opening in the medial wall of the orbit also exposes the infundibulum. Now we'll move back and look at the nasopharynx. To do that, we'll put the nasal septum back in place. Here's the right half of the nasopharynx. The openings from the two nasal cavities into the nasopharynx, here's the right one, are called the choanae, or posterior nares. The roof of the nasopharynx lies underneath the basilar part of the occipital bone. The back of the nasopharynx lies in front of the atlas vertebra. Here's the anterior arch of the atlas. In the mucosa of the lateral wall of the nasopharynx, there's a pronounced inward fold called the torus tubarius. It's produced by the inward projection of the cartilage of the auditory tube. The mucosal opening of the tube is here. Behind the torus tubarius is a deep recess, the pharyngeal recess. The floor of the nasopharynx is formed by the soft palate, which forms a highly mobile partition between the nasopharynx and the back of the oral cavity. The nasopharynx opens downward into the oropharynx. The soft palate can move upwards, backwards, and downwards. Its movements, which are important in swallowing and in speech, are produced by several small muscles. These converge on the soft palate from above and from below. Most of them insert on a sheet of aponeurosis or tendon-like material that occupies this part of the palate. In this section, we'll see only the palatal muscles that come from above. We'll see the ones that come from below in the next section. The two that we'll see now are the levator palati and the tensor palati. To see these muscles, we'll remove the mucosa of the nasopharynx. Here's the end of the cartilage of the auditory tube. Here below it is the levator palati muscle. Its full name is the levator veli palatini. Levator palati arises here on the petrous temporal bone. It passes along the underside of the auditory tube, runs downward and medially, and joins in the midline with its fellow from the other side, forming a sling. Levator palati moves the soft palate upwards and backwards. To see the tensor palati muscle, we'll remove the levator. Here's tensor palati. Tensor palati arises from this area, just above the root of the medial pterygoid plate. Here's the edge of the medial pterygoid plate. The fibers of tensor palati pass downward and forward towards the pterygoid hamulus, which is here. The tendon of tensor palati makes a complete 90-degree turn round the pterygoid hamulus. Here's the tendon emerging. It passes medially to insert on the palatal aponeurosis. The action of tensor palati is to tighten the palate when the tongue presses up against it in the act of swallowing. It also may help to open the auditory tube. We'll end this section with a look at the auditory tube. Here's the end of the cartilage of the auditory tube. The cartilage doesn't form a complete tube. It's open on the underside. Here's the cut edge of the mucous membrane, which forms the real auditory tube. It passes backwards and laterally to reach the cavity of the middle ear. The function of the auditory tube is to keep the pressure inside the middle ear the same as the pressure outside it. Now, let's review what we've seen of the upper part of the air passage. Here are the nostrils, or anterior nares, the columella, the lateral cartilage, the alar cartilage, the septal cartilage, the nasal vestibule, and the olfactory area. Here are the conchae again, superior, middle, and inferior. Here's the nasopharynx, with the torus tubarius, the pharyngeal recess, and the soft palate. Here's the semilunar hiatus and the infundibulum. Here's the levator palati, the tensor palati, and the cartilage of the auditory tube.
Okay. Yan. So, hello? May I ask everybody to please turn on your camera again? Okay, thank you. So, do you have any questions from the videos that we showed earlier? Mukhang clear? Okay, and I hope it reinforced the lectures earlier, no, that were given to you. Okay, so any other advice po from our faculty members for this gross lab session? Wala na po. Okay, mukhang we are ready to log out. So if you don't have any questions, we will dismiss you earlier, at least for 15 minutes early for today. And then we'll have your pre-SGB mamayang 3 o'clock. Okay, so see you again. I hope you have already downloaded the case. Okay, so yung may study questions, yun, discuss nyo muna. Discuss it as a group. And then after discussing it and arriving at a very good final diagnosis, if you can at this point, then you can proceed with planning for your SGD presentation next week also. Okay, so having said that, thank you guys for staying on. I hope you enjoyed today's video lab.